Hi, Cynthia Allen here, and we're back again with the Feldenkrais Awareness Summit. We're wrapping up the track on structure and tensegrity, and I'll introduce our guest in a moment, but first I just want to go over a couple little housekeeping things. If you've been tuning in all along, you know that we're encouraging you to open up and find the chat on whatever device that you're using and to have conversation with each other. We will be having our live panel discussion right after this talk, and we can fold some of your comments in, your questions into that talk, or if you can hang around after this for the next panel discussion, we'll be able to have you participate during chat at that time as well. Also in the background, within the chat area, you'll find our very talented Arlene Klein, and if you're having some problems, she will be able to interact with you and try to help you solve those. Or if you're having problems at any time, of course, just email us at support@futurelifenow.com. So I'm getting ready now to take us into the wrap-up, the final talk in this particular track on structure and tensegrity, and I'm with great pleasure introducing you to Dr. Robert Schleip. He's the director of the Fascia Research Group at, is it Ulm University? Ulm?
Yes,
Ulm University. Yeah, and the research director of the European Rolfing Association. He has a master's degree in psychology from Heidelberg University, and I'm not sure what you got your PhD in. Did you get it in?
Human biology. Sounds
human
like
biology.
a mouthful. Yeah.
Okay, human biology. And then in addition, Dr. Schleip went on to train, after becoming a Rolfer, he went on to train to be a certified Feldenkrais practitioner and has been practicing both of those modalities for a number of years. And then in 2004, took a big turn, I would say, or it appears to be a big turn into research. So finished his PhD thesis on active fascial contractility.
Yes.
Contractility.
The ability
of fascia to contract. So to actively be contractile. So, and he was been awarded the Vladimir Janda Award in 2006 and co-initiated the first Fascia Research Congress held at Harvard Medical School Conference in 2007. And thank you so much for joining us, Robert.
Thank you for allowing me to share some of my inspiration.
Yes, well, you are, you certainly have been inspiring to many people, and you have a very interesting background. And I would like to hear a little bit about how you got into Rolfing. So you went from psychology as an initial interest, and then into Rolfing somewhere in here, and then into Feldenkrais. And maybe you could just give us a little snapshot of how that journey went for you.
I studied university at the, I studied psychology at Heidelberg University, but that was pretty cognitive. But already at that time, Gestalt therapy and encounter and what we called body work was influencing many of us. And then I went to the United States, which was the golden mecca at that time, to go to California. And I got introduced to both the Feldenkrais method and to Rolfing at the same time. And it affected me personally much more than all the talking therapy I had been doing before. So I was strongly inspired to learn and to use those modalities. However, my path led to become the first certified German Rolfing practitioner, although I had been attracted to the Feldenkrais method already strongly before. And then after having been a Rolfer, I did the 4-year Feldenkrais training. And now I have been a practitioner in the Feldenkrais method and in the Rolfing method for over 30 years. And just in the last 10 years, I changed my emphasis from a practitioner to a scientist, to a researcher. And I have found that very interesting. So in this talk, I will come back to my people, to my colleagues, with hopefully some important insights that I have gained in those 10 years in the scientist land.
Wonderful. Well, we're looking forward to it. I'm glad that you've been able to continue to grow and find things that are interesting to you. And, this is about the theme is the map is the territory, and I think that you're very much trying to help us expand our territory and have been expanding your own by going into the research world. It's not real common that people who are into body work or modalities around movement get really interested in the research aspect, so we're glad that you have. And I think you've got some slides to share with us about some of your research and what you've been finding.
So let me see if I can grab my slides in the background. You tell me when they show up. They are not yet there.
You're there.
Okay. So my talk was given the title Fascia as a Sensory Organ, and new insights about the body-wide connective tissue network, particularly with implications for manual and movement therapists. And this has been a great new avenue for me and also many of the colleagues, that when we look at fascia, which is this seemingly colorless and structureless connective tissue shown here on the next slide, how it is usually presented to medical students when they do their practical anatomy course. This was usually regarded either only as a packing organ, that is the standard view in classical Western anatomy, so something that you cut away. So most anatomists and most medical students, they cut this white, seemingly omnipresent packing organ. They cut it away, it takes many hours of work, and they throw it into these buckets, into these temporary waste buckets that you see on the upper right corner there. And then you have the real anatomy there. And of course, people in complementary medicine knew better. Andrew Taylor Still knew it better, the founder of osteopathy. Dr. Eiderolf knew better, and also Moshe Feldenkrais knew better, that this is not just as important or unimportant as the wrapping of a Christmas present, and that you can understand the organ without the wrapping, as Western anatomy has been doing, but that it is a very important influence in muscular force transmission. And that was the viewpoint that Eiderolf was passing over to us, and there was a very long, healthy debate between Moshe Feldenkrais and Eiderolf, whether it is more important to change the neural body organization, the body map about the body, so the brain's map about the body, whether it's important to change the neuromuscular coordination, or whether it is more important to change the mechanical gluing and stiffening of this connective tissue matrix. And they had a lifelong debate around it. And what neither of them was aware that this white stuff, as it's shown here, but please be aware, this is the cadaver view. In a living body, it looks very, very different. It looks more sparkling, more shiny, more transparent. But they had not been aware of the new discoveries that have now been done, that this body-wide network is now considered as one of the richest organs for body perception. And this is now a new calculation that has been done by a colleague of mine at Leipzig University, by Professor Martin Grunwald. He calculated how many sensory nerve endings are in the body-wide fascial net. And he came to this incredible number of more than 100 million sensory nerve endings in the body-wide fascial network. And that is at least one order of magnitude higher than our so-called first sense, the sense of seeing that we have. However, this definition or this calculation is based on the new, let me see if the size here is large enough. Okay, so that's better now. No, it's still the same. My slides don't show large enough. Cynthia, the last line that I see is, I think I need to start new. There is something happening. Sorry about that.
It's okay, take your time.
Yeah. Because the slides are showing in a
It does look like they're cutting off a bit, doesn't it?
Yeah. And now, do you see them in the presenter view?
Yes,
Okay.
I see the whole slide now.
Okay, so that's good. I'm following now the new definition of fascia that has been proposed at the very first International Fascia Congress in 2007. That was the first scientific congress looking at fascia as a body-wide connective tissue network system. And we suggested not only to include what you could call proper fascia, that has been the old definition of fascia. These are dense, irregular, sheet-like connective tissue membrane sheets. However, an aponeurosis, or the intramuscular connective tissue, or the subcutaneous loose connective tissue, they were often not included in the term fascia. However, we were inspired by looking at fascia as a body-wide connective tissue tensional load transmission and sensory organ. And therefore we propose to include basically everything that a layperson would describe as connective tissue. So it means tendon sheet is a part of the fascial network. Even the Achilles tendon, which is not sheet-like, is also a local specification of this body-wide fascial network. And even the intramuscular connective tissue that's shown on the, on the lower left picture on the lower row, it shows you the multiple bag-like containers, not only around the muscle, but also within the muscle, around the many muscle fiber bundles and even around a single muscle fiber. And this is a new concept of fascia as a body-wide tensional, collagenous, fibrous network, that all these bags are part of a body-wide load transmission system, but as we have now learned, also of a highly, richly specified perceptual system for perceiving our own body. And this is something that Eidorff had not been aware of. And if Moshe Feldenkrais would have known that if you want to focus on proprioceptive perception of your body, that it is much more powerful to stimulate the fascial membranes rather than the muscle spindles or the skin or the deep joint receptors that are close to the joints, they would have had a very, an even more fruitful dialogue among each other. So as a RAFA, we learned with fascia not as a sensory organ, we were working with fascia as a force transmission and force limiting organ. And this is a new insight now, that you can also work with fascia in order to stimulate sensory nerve endings that will help you to reorganize your concepts about your body in your brain. Now the question is, what kind of nerve endings are in there? And certainly many of them are potential nociceptors. So it means myofascial pain may originate, at least sometimes, not from the muscle fibers, not from the joints, but from the fascial membranes. And that was recently shown to be the case for delayed onset muscle soreness. So for example, if you go hiking and you are not very well prepared for it, and you hike 3, 4, 5 hours downhill, you are prone for delayed onset muscle soreness. Not immediately afterwards, but on the next day or on the next 2 days, you have sore muscles. And everybody in sports medicine knows this as delayed onset muscle soreness. And the common concept was that you have micro injuries, presumably in muscle fibers, but that was not very clear. And that these muscle injuries leads to edema, so to a tissue swelling that then has the climax of the swelling, the peak of the swelling, the peak of the fluid increase after 1 or 2 days. And then it's not the injury that hurts you, otherwise it would hurt immediately during the hike. However, it is the fluid pressure. However, it was not clear where are the free nerve endings that are signaling that pain. And this is now one of the 2 studies that have been done in the last few years, at which they tested people with delayed onset muscle soreness. And so they had them do movements that produce the delayed onset muscle soreness. And then they came with a very small electrical needle impulse to test whether the subcutaneous connective tissue on the upper picture on the lower right, I cannot put the pointer right now. So you see the upper segment is the subcutaneous connective tissue. Then you have the white layer, which is the fascia of the biceps brachii. Underneath, you have the muscle fibers of the biceps brachii. And then again, you have a fascial envelope of the muscle underneath, the brachialis. And then again, you have the muscle fibers. And what they found out is the sensitive nerve endings are not in the middle of the muscle. However, they are in the envelope. So this means if you have sore muscles after eccentric contractions or after hiking downhill for several hours, the pain is not coming from the muscle belly, it is coming from the fascial envelope. So we know what's hurting, at least in this example of myofascial pain, is the fascia. It is not the muscle fibers on the inside of the muscle. So we know that fascia can be the source of pain. And this has been recently shown with histological studies here from Professor Menze at Heidelberg University. He identified not only nerves in fascia, but nerve endings. And some of them are multipotent, so they can signal pain, but they can also signal temperature or other stimulation modalities. However, there are also some specialized free nerve endings, here shown in the picture C, that are specialized on nociception. So they have no other known function other than to signal the body that there is a potential danger, and it's a suggestion to react with a pain perception modality. So we know fascia can be a source of nociception. In addition, there have been many nerve endings now found, shown here on the next picture, which are linked with the autonomic nervous system. And they are very rich, and they are sympathetic nerve endings. Some of them terminate close to blood vessels, and then we think we know what they do. They regulate the dilation of the blood vessels. However, there are also many of them where we don't know the function, and that is a very intriguing challenge. I hope I will still learn about the answer during my lifetime. What are the sympathetic nerve endings in fascia doing that are not close to blood vessels? So we know there is a very intimate link between the autonomic nervous system and between fascial tissue regulation or fascial tissue properties. And possibly there is, or these sympathetic nerve endings could have to do with emotional stress. And this is also one of the experiments that has been done at Heidelberg University. They call it elegant research, but you can judge yourself whether you think this is elegant research, in which they exposed rat animals to mild emotional repeated stress. And interestingly, the ethics committee, which is totally against any kind of animal torture, they had to allow this experiment because the researchers said we are doing the same thing to our children. What they did to the rats is they put them into forced immobility into this plastic container shown on the left, in which they can freely breathe. However, they cannot turn around and do whole body movements. So it is like if you tell your students, when you are in class, don't move around, keep your sit bones on the chair so other people can see something. However, for these rats, they don't like it, and you can hear it in their screaming. However, you only do that for 1 hour per day, and you do it for 12 days consecutively. This mild emotional stress, in which you don't put any pain, physical pain on them. However, you restrict their innate movement behavior. When you then examine them and compare them with normal rats, first of all, you don't see a difference. However, then you discover that in the spinal cord, at the area where sensory information comes back, to the dorsal horn of the spinal cord, you have an increased resting activity. And in addition, the normal fields that are shown, for example, on the back, on the picture on the right, on the left, that are transmitting their stimulation to a certain level of the spinal cord, this area has become larger. So it means each level of the spinal cord has a larger body area that can potentially irritate or stimulate it. And the most important thing, or most interesting thing, is these animals, when they tested 7 different kinds of pain perception, for example, piercing or temperature pain, etc., only had 2 types of stimulation for which they were more sensitive. One is an increased sensitivity for pressure pain. So it means if you pressed for it was 100 grams per square inch, it was suddenly painful to them, and before this had not been painful. So the pressure pain threshold got lower. And also repetitive stimulation. If you stimulate the same point 10 times, how much more sensitive it is after 10 times of mechanical stimulation compared with the first time is a measurement for the so-called wind-up phenomenon. And that was also increased. Now you can criticize that very well in saying we are not rats. And this cannot be taken one-to-one over to human patients. However, the same researcher, Dr. Tessarts from Heidelberg University, he looked at over 100 patients with a history of low back pain, and he compared those who had, additional to their acute low back pain, a childhood abuse post-traumatic stress disorder, often many decades before. And he looked how is their sensitivity different as opposed to other low back pain patients. And he found a very similar change in their responsiveness to different stimulations as these rats have. So on a similar way, these patients who had a long-term history of post-traumatic stress disorder, in those cases it was sexual or emotional child abuse, they had an increased sensitivity for pressure pain and also for the wind-up phenomenon in terms of repetitive pain stimulation. Interesting enough, the sexual abuse seemed to have more increase on the pressure pain, whereas the emotional abuse was more with the repetitive stimulation. So this is now clinically quite relevant. If you work with fascia and you are applying pressure from the outside, if you have a history of chronic stress, and maybe that is one of the answers to the question I posed myself before, what is the importance of the link between the autonomic nervous system, particularly the sympathetic part of the autonomic nervous system, and fascial properties, that this could be one of the influences there, that if you have a history of chronic emotional stress, just like it had been shown with these rats or with repeated child abuse here, this could change the sensitivity of some of these free nerve endings that you have in fascia. Now, when you work with low back pain, there has been a new study looking whether the stiffness of the lower back muscles, the fascia and the muscles, is really important. Because if you trust the practitioner who touches the client, and also if you trust the perception of the client, the side of the body on which they have their chronic low back pain feels stiffer. And that was my dogma as a Feldenkrais and Rolfen practitioner, at least for 2 decades in my work, that you have the pain muscular spasm cycle. So if somebody has emotional stress, their muscles go into spasm, then the heart muscles create pain by either pressing directly on a nerve or by impeding the circulation and the blood supply. And then the pain aggravates the muscular spasm even more. So that would mean that the painful side of the lower back should be stiffer. However, when they tested it with this mechanical indenter, there was no relationship. The low back in people who have chronic low back pain is not stiffer in terms of resistance to 1 millimeter indentation if you test it not with a human hand, but you test it with this industry-made force torque that has been shown here on the left. However, when you ask these chronic low back pain patients, how strong is the push from this indenter? Is it 1 kilogram? Is it 5 kilograms? They are much less precise than healthy patients are. They overestimate the amount of force that you are exerting on them. That makes sense because you can say their proprioception is impeded by an overfocus on the pain. However, when you ask these low back pain patients, is the first pressure stronger or is it lighter than the first pressure? They are more sensitive than healthy controls. And that is unexpected. So,
say that again. I didn't quite hear that.
So when you ask them, is the first pressure, if you do 2 indentations, you press them 2 times, and you ask them which of the 2 times is stronger, the first one or the second one. In healthy people, you need a difference, let's say, of 15%, so they can tell you, just as an example. But in low back pain patients, they can feel a difference of 2% or 5%.
Wow.
It means they are more sensitive than normal patients are for a gradual difference, but they are less sensitive for the absolute amount of force. And that doesn't make much sense if you look at it in terms of, is the proprioception, you could call that proprioception, if you call them how much force is there. You don't ask them for pain, you only ask them how much weight is my thumb pushing on your back. And the researchers, they came up with the explanation that maybe this chronic low back pain experience has nothing to do with the stiffness of the tissue, but with the protection mode of the brain. If the brain is in a danger zone and is in a protection mode, then these 2 features do make sense. Then it makes sense to over-exaggerate the absolute amount of force and to be hypersensitive for a gradual difference. So that was the hypothesis, that the chronic low back pain difference is not the stiffness in the periphery, it's the protection mode, the fear mode, the avoidance reaction of the brain. What do you do if you have a hypothesis and you are a scientist? You test it, and that's what they did here. What they did is they made a sound, a squeaking sound in addition to the indentation. And I need to show it to you, otherwise it doesn't come across. So I hope you hear the squeaking sounds that they have been making. And whenever they did that, let me interrupt this. So whenever they made the squeaking sound, the low back pain patients totally overestimated the amount of force, much more than the healthy patients. And when they made a soothing sound, which is like poo, like a relaxing sound, then they thought the pressure is much, much less. So for them, it means the experience of pressure or how much force your lower back has, and probably also of the amount of pain you have when you bend forward or when somebody pushes with their elbow on your lower back, a Rolfing practitioner or Feldenkrais practitioner, has not so much to do with what is happening under your hand. It has to do with what the brain is associating. And so that I look back at 30 years of Rolfing and Feldenkrais practice and how many hundreds of, probably thousands of patients I've been able to help out of low back pain by touching and melting stiff areas in the lower back. But now listening to this research, it means that the success of the treatment was not influenced by making the lower back softer. It was the tone in my voice. So if I would have said to them, "You relax like this," they would have tightened up. But I said, "There we go, with a foggy, warm voice. Do you feel it softening? Yeah, there we go." So any good practitioner is having this empathetic voice, and you can see it in their breathing. If the practitioner fantasizes, even by illusion, that the connective tissue is getting softer, they mirror it back to the patient with their breathing, with their voice, etc. And this is the main signal that then will influence the brain of the client to say this is no longer dangerous. So this is a provocation to us Rolfers, in which we thought the actual stiffening in the peripheral area that we are treating is of importance. At least for chronic low back pain. I don't think you can generalize that for any kind of acute myofascial pain, but for chronic low back pain, this amount of research is actually quite overwhelming. Let me skip forward because of time reasons to the new theory that I suggest that explains a lot of the beneficial effect of Feldenkrais practice, but also osteopathy, Rolfing, and other manual and movement therapies, which is a new concept that at the level of the spinal cord, proprioceptive stimulation and myofascial pain are mutually inhibiting each other like water and oil. And that is regulated by some particular neurons that I will show in the next slide. They are called WDR neuron. I'll address them in the next slide. But there have been many experiments to show, for example, if you stimulate a person, that has been done in Australia, into acute low back pain. So you inject a hypertonic saline injection into their lower back, into the erector spinae, and then you have the person sit on a rotating disc with their pelvis, and the disc starts to rotate 1 degree per second, either to the right, taking the pelvis with it, and also the legs hanging down, but not the trunk, which is fixated with 2 ribbons to the back of the chair, which is stable in the room. So you have a segmental movement of the pelvis in relationship to the torso. And you ask the client, who is blindfolded, tell me which direction your pelvis is turning. And none of us is able to recognize whether it's going to the right or the left if it's only turning 1 degree. But hopefully all of us are able to recognize it if it's turning 45 or 90 degrees. And this is one of the most acute and most accepted tests for regional specific proprioceptive accuracy. And they showed whenever you give somebody low back pain, their proprioceptive accuracy is impeded. So they need almost twice as much of a joint movement in order to recognize it if they cannot see it. And that is one of the examples of this dichotomy, like the water and oil, each one inhibiting each other. So if you push up myofascial pain, as they have been doing in the sitting experiment, proprioception goes down. And that has also been shown in the other direction. In this experiment, for example, here, they used the poison that you have in the fugu, in the bufferfish from very expensive Japanese restaurants. And if you inject that into animals, as you see here on the left, before you inject that heterodoxin, that's the medical name on it, the myotatic stretch reflex, for example, if you push into the patella, then you measure how quickly the muscle reacts, and that's to test for the proprioceptive system is very clear. However, when you inject that inhibiting substance, it's no longer there, as you see on the lower picture on the left. But what is happening with the free nerve endings that are there for nociception, and that is shown on the right. Before this poison that inhibits proprioception, you stimulate a tiny bit and you get a medium reaction, as you see in that indentation. However, when you inhibit the proprioception, the same small stimulation leads to a strong painful reaction. And this is this concept that we now look at, and here's the name, wide dynamic range neurons. And they are in the posterior horn of the spinal cord, and they are open for both for the blue-colored, in this illustration, proprioceptive stimulation, but also for the free nerve endings that are associated with potential nociception. The new insight now is that they are hungry for stimulation, and that makes them different from many other neurons that are in the spinal cord. So if they get regular functional proprioception, everything is fine because they have something to report every few hours. However, when there is not enough proprioception coming into one region of the spinal cord, or let's say coming from your lower back or from the right side of your hip joint, then they take out a magnifying glass, so to speak, and they fish for potential nociception. And then even a minor potential nociception, let's say a leg length difference of 0.5 millimeter, how terrible, that leads suddenly to SI, sacroiliac pain or headache or anything like that. So this is a concept here that proprioceptive richness can inhibit myofascial pain and vice versa. So what we want to do as movement practitioners, what we want to do as manual practitioners is to provide proprioceptive stimulation again, so that these damn WDR neuron, wide dynamic range neuron, stop fishing actively for potential minor, ridiculously small nociceptive stimulations. So what is the best way to stimulate proprioception? If fascia is our richest sensory organ for proprioception, then fascial stimulation can be a very, very good input. And one of the fascial stimulations that we have developed as Rolfers, but we are not the only ones, are the Ruffini receptors. And they are very receptive not to vertical pressure, also not to longitudinal stretch along a tendon, but to diagonal, tangential shear manipulation that you have there. And very interesting, when you stimulate them, they not only lead to a local tissue relaxation, but also to a global autonomic nervous system shift from a sympathetic activation to a more parasympathetic state. So this is, for example, a nice combination of a Rolfing technique. I use the back of my hand on the fascial envelope of the upper trapezius, and I look for the direction, the osteopaths call that local listening, in which I feel the tissue yields the most. And then I go very, very slowly in that direction, and I ask the client to slowly turn their head at the slowest continuous, not abrupt stop and go segmented movement. So find the slowest continuous rolling movement of your head, maybe over 3, 4, or 5 breathing cycles for some of the patients, rolling your head a little bit to the left. That means lengthening your upper trapezius on the right side. And then later you can do it rolling your eyes only, or leading with the eyes and following with the head. And then both the client and the back of my hand are ironing, are spreading the fascial container around the upper trapezius. While I'll do that, I look at the lower belly breathing of the client, because if you don't have heart rate variability apparature, or they have an Apple Watch to tell you, the lower belly breathing can show you as soon as there is a shift from sympathetic activation to more parasympathetic activation that you have there. A very interesting dimension is the question, how important is mindful attention of the client? And that had been a long debate. whether it is okay for the client to start daydreaming and relaxing, or whether they should pay conscious attention to each and every touch that you provide as a manual therapist. And there has been a quite helpful research study by Lorimer Mosley. He treated what is called complex regional pain syndrome, or morbus Sudeck in some countries, in which people who usually have a cast that makes some problems, so if they have a broken arm or broken leg, and they have a cast for the wound healing, and if the cast makes some irritation problems, quite often they have long-term sensitivity problems, not only at the part of the cast, but on the whole limb, on the whole arm, on the whole leg. Many people who work in hospitals, they know this condition. And I don't know any manual practitioner who says, I can heal that in 80% of the cases with one session. It's usually a very complex and long healing treatment history that you have there. What Lorimer Mosley did is he only focused on proprioceptive stimulation. So he made 5 points at the back of the hand of the affected arm, and he made a photograph of these 5 points because he asked the client to put the real hand behind a screen. So they could not see the 5 points. They only had a picture of the 5 points and the hand in front of them. And then the experimenter used a pencil, like I have one here, to touch one of the 5 points and ask the patient, which of the 5 points am I touching? They could not see it, but they were asked to recognize it from the inside. Is it the point that is closer to the thumb, or is it the point that is most closest to the small finger, for example? In addition, they asked them, am I using the sharp end of the pencil, or am I using the rubber end of the pencil? So it's a clear proprioceptive stimulation, and you do that for 10 minutes a day only. And after a very short period, I forgot how many weeks it was, so let's say 4 weeks, the majority of them not only had better proprioception, that means they were more accurate in their recognition where the hand has been touched. However, also their pain has been gone. So this is a much more effective treatment than any other manual treatment that had been focusing on the painful tissue. Here they focused on the brain. So this already is a spectacular research. That means pure proprioceptive stimulation provided here on the skin can be a much more powerful manual therapy support than working on the painful elbow, etc., and the circulation and the fascia there. However, what Lorimer Mosley did in this study, he compared it with a group of patients who got the identical peripheral stimulation. So they also got provided with 50 touches in 10 minutes. However, they could read a book and they did not need to give verbal feedback where they have been touched. So this is a brilliant experiment to provide how important is a tissue stimulation and how necessary or helpful or not is it if the client pays attention. I know many discussions between Feldenkrais and Rolfus and other manual therapists where everybody has wonderful examples, quoting hypnotherapist Milton Erickson, etc., that the client can learn without conscious attention, that their subconscious learns even better, blah, blah, blah. It means all plausible theories, but no clear controlled experiment. You need a controlled experiment. And this is the first experiment that I know where you have two groups where the only difference between them is the attention, the mindful attention. Either it's directed to the touch or it's not directed to the touch. So let's say the group below, where they had the mindful attention, took 4 weeks to heal. Question to you, to each in the audience, how many weeks would it take in the other group to get the same improvement? Does it go faster? Does it go slower, or is it the same speed? So you could argue maybe it takes slower. Maybe it takes, instead of 4 weeks, it takes 8 weeks. Maybe it takes 10 weeks. Now the result was very shocking. No improvement at all at the upper group. You can treat them for 1,000,000 years if they continue like that. They will love you as a therapist. You allow them to daydream. They will give you Christmas presents. They will be there every Thursday at 2 p.m. in your waiting room for the next 10 years. And you will treat their children and their grandchildren. Sounds familiar to many of us who have a regular practice. However, it means for the myofascial pain condition and the body mapping of their brain, there was apparently no improvement in that. So I'm not sure whether we can generalize that for other pain conditions, but for pain conditions that are associated with a diminished proprioception, that could be one of the major factors. We need regional, specific, mindful attention of the client at the area in which we are touching them or at the area in which the movement happens. Now, let me close this talk at one of the most interesting subjects, which is not nociception, not proprioception, but interoception. And that has something that I had not been specifically aware in terms of research and literature and how to stimulate it as a Feldenkrais endorphin practitioner during the first 20 years of my practice. Interoceptions are sensations of our body that are related to physiological need. For example, coldness, warmness, so in terms of temperature regulation, but also hunger, for example, is interoception. So it's not related where is the body in space. It's also not related to biomechanics and to locomotion, but it's related to physiological organ functioning. And that has been shown that this is stimulated, that this involves free nerve endings, basically in connective tissue membranes, in our guts, but also around our muscles. And they do not project to the somatomotor cortex, where you have your body schema and your body image. They project via the pathways shown on the right. They project to the cortical insula. So that is gray matter in your forebrain that is folded inside. And interesting enough, we humans have a direct, much stronger highway shown here in red between the periphery in our body and the insula. So we should have a stronger interoception, and many have argued that the sense of self, of having an identity, not having an identity, of having a certain mood of the day, etc., is more influenced in us humans by our interoceptive condition than by our proprioceptive condition. And very interesting enough, the majority of the nerve endings in fascia are related to interoception more than to proprioception, if you calculate the amount of them. And as I have shown here on this slide, proprioception projects via the pyramidal tract to the somatomotor cortex. And that's where we have learned, where we have focused on how is the somatomotor cortex being influenced and what touch allows the client to restructure their body schema, for example, that is partly organized in the somatomotor cortex. However, the visual perception of the client, how alive do I feel today? How heavy do I feel? How sore or how old do I feel when I get up in the morning? That is interoception. How hungry am I? How light, how heavy do I feel? How much tingling do I have? This is influenced by interoception that projects to the insula. The insula always associates a body perception with an affective coloring. So whatever change you have, whether it's warmer water or colder water, you can always say it's more pleasant or less pleasant. With proprioception, sometimes that is impossible to say. Whether your shoulder is a millimeter more forward or backwards, if you ask them what is more pleasant, often you cannot say. But interoception, you always have an emotional attitude to it. Now, this is interesting because many of the clients that we treat, they need proprioceptive stimulation because we know from the literature that this is primarily a proprioceptive dysfunction. For example, chronic low back pain. Here it would be good to give them proprioceptive fascial tension. Also phantom pain, ADHS or hyperactivity syndrome, scoliosis, complex regional pain syndrome, as I mentioned, scoliosis, and probably many other myofascial pain syndromes. However, in my practice, I have as many patients who have a history of post-traumatic stress disorder, who have obsessive compulsive disorders, or who have eating disorders or irritable bowel syndrome, for example. And for them, stimulating proprioception may be barking up the wrong tree. You are treating the wrong system of body perception. Now, I made a very subjective list. Of course, it's not black and white. But if I give postural education to a client with low back pain, that is expected to be very helpful. However, if I give postural training to a client with post-traumatic stress disorder, he may not improve at all, possibly, because their disorder is in the interoceptive signaling. So classical Feldenkrais exercises, not all of them, are ideal to feel the different touch of your lower back on the body surface. Is your right shoulder blade having a broader surface of touching than your left shoulder blade? How is your head over your shoulders, etc.? That could be the most powerful therapeutic avenue to choose if you have a patient with one of the conditions shown on the left. However, that had been shown on the left before, like with low back pain. However, if you have somebody with post-traumatic stress disorder, with eating disorders, it may be better to use visceral osteopathy, to do a yoga that is not focused on what exactly is the position of the middle thoracic spine. That would be a typical question in Iyengar yoga. Not all Iyengar yoga, but in the typical beginner classes in Iyengar yoga. But that you ask him, do you feel the tingling in your lower back? Do you feel the energy streaming, whatever is streaming there? But you ask for interoceptive sensitivity feedback that you get from them. So this is a very rich area where there is a lot of research happening recently. And an interesting aspect is proprioceptive perception can happen very, very fast. So the transmission time from these myelinated nerve endings, the Golgi receptors, spindles, etc., happens within milliseconds. So if you're an athlete and you ask yourself, where's my right shoulder? Do I have a lordosis or not? You can often answer within a fraction of a second. However, if you ask for interoceptive signaling, is your right leg heavier than your left leg? And you don't mean the objective weight, you mean the subjective weight. Or in which arm do you feel more at home? This is a very nice question in terms of embodiment. Then you want the client to take more time, maybe to take half a breathing cycle, to close their eyes and say, I feel more connected with my left arm after this treatment that we had. So this questioning and fishing for more slowly processed perceptual reports, how are your guts responding? That may be an area that can very easily be implemented into standard Feldenkrais practice, whether it's functional integration as a manual therapy or manual education at the table, or whether it's awareness through movements lessons on the floor. That with somebody with low back pain, you would continue to ask them which shoulder blade is touching the table more. However, if you have somebody with compulsive disorders, if you have somebody with eating disorders or with post-traumatic stress disorders, you may ask them, which leg are you more at home? How alive do you feel? How warm do you feel? Do you feel the tingling? How old is your left leg? How young is your right leg, etc.? So let me summarize in terms of clinical applications of some of these research insights. Fascia provides one of the richest network for perceiving our own body. It is not just the muscle spindles, which are in the muscle fibers. It is not just the deep joint receptors, which are fairly insensitive, unless you go to extreme range of motion changes. But for physiological movements, it may be mostly the stretch receptors into our body-wide perceptual network that is now called fascia. Myofascial nociception is largely influenced by cortical effectors, such as the emotional stress that I was reporting from the childhood abuse, but also from the rats that had been exposed to emotional stress, and also to the protection mode, as has been shown in the squeaking noise that I was showing you before, that this is a dramatic factor for the myofascial pain that you may feel. And finally, the experiment by Lorimer Mosley, that for at least those myofascial pain conditions, like complex regional pain syndrome, in which the proprioception is dysfunctional, you need mindful attention of the client in order to get an improvement. And finally, for us manual therapists, but also for movement therapists, it is important to pay attention not only to proprioception as a healing quality to the client, but that some of them may not need to get better proprioception, but they may need a more delicate interoception. And this is a very rich and promising area. Let me finish by thanking all the colleagues who have been helping me. This is the group of us here at Ulm University. And the beauty of fascia, fascia is a connecting organ. So the people in the fascia research field, it's a non-hierarchical field very much. It's a networking field, and you have many different disciplines sharing their inspiration and their question. And I invite everybody to enter this field with new questions, with new observations, because fascia is a connecting organ. Thank you very much, Cynthia.
Thank you very much, Robert. It seems like you are you're certainly one of the pioneers is trying to help us understand an area of the body that really has not been looked at much until the last 20 years, perhaps. And we see right now research coming out where there's some new aspect of anatomy being discovered. In a way, you are helping us to discover fascia, because it was very discounted. I mean, we knew it was there, but discounted, held to a small range and function. And this is incredible. Now, I have to say, at the same time, I'm sure you're aware that there are people who are are saying fascia is being highly overblown, and there's whole groups that seem to be devoting themselves to sort of naysaying the role of fascia at the same time that this new research is coming out. Would you just say that's probably just ignorance at this point?
Oh, no. The people who are pointing at the importance of the nervous system, I was quoting a lot of the research.
Oh, sure. I know you were.
So in this talk, they have a good point there. And so if you're just meshing on fascia to make it softer, you better listen to these people. However, fascia is a sensory organ. And in terms of the sensory organ, if you want to stimulate the brain, you can talk to the client, you can show them a movie, but you can touch them. And when your touch is fascia informed, you will have a much more potent cortical reorganization. So I don't see a dichotomy between fascia therapy and neural reprogramming. It belongs together.
Wonderful, wonderful. I like that. Well, we really appreciate, you've just given us so much to think about. It's a very rich discussion, and I think we'll have a lot to say in the panel discussion that goes on afterwards. You also have written a book, which is Fascia in Sport and Movement. Does that go back a ways for you now, or is that fairly new? I haven't gotten it yet, I'm afraid to say.
No, I think it's still the best book. I'm one of the editors of that book.
Mm-hmm.
So we have 16 different authors. But if you are a movement therapist, and you want to learn more about including fascia, in your treatment and your explanations and questions. I think this is still the best book so far.
Great.
It's called Fascia in Sport and Movement by Handspring Publishing.
Thank you. Thank you. And Robert, where you said you hoped in your lifetime you get to see some of the outcomes of this research. I guess that might be the answer to my next question is, where would you like to expand your own personal map, either for yourself personally or in your field?
I hope I continue to have the privilege to be a mediator in this field. The field is bubbling. There is everywhere new laboratories in the world are including fascia now, and right now I know most of the laboratories in the world focusing on fascia. Not all of them. It's so far only 24 of them, so it's not a miracle to know them. So this is a privilege that I have, that I know the researchers, I can report, but they are doing it different there. But here we have a new observation that comes from the Bowen people or from the osteopaths. Are you able to measure that and to develop more technologies? Fascia is not new, but the Western science was not able to measure it because it was very thin. But now we have measurement tools besides our hand, besides our own body perception, in which critical Western science can examine fascia in a more quantitative and more scientific manner. And that is very exciting. So I hope to continue to be a bridge maker between the scientists on one hand, who are questioning everything, including their own assumptions, particularly those, and between the much more open-minded therapists in many ways.
That's great. I can see a sort of a panel, a fantasy panel, I guess, and I could see yourself, I could see John Sharkey, mediating between Ida Rolf and Dr. Moshe Feldenkrais, and just bringing this new information out to these founders and to then hypothesize in what way would it have shaped the work as it's happening today.
Yeah, and fascia unites us. So in the past, when I was at the Feldenkrais training, I was hiding my identity as a Rolfer and vice versa. Mm-hmm. But now I don't need to hide because fascia unites us. Fascia is not only an envelope, it's a sensory organ and the most richest we have. Right. For stimulating proprioception and interoception.
It's wonderful. And of course, even though we say in Feldenkrais that we're not focusing on fascia, we are affecting fascia.
You are, if you look at Moshe's
hands. And I feel that in my hands every day as I work with people one-to-one, that even though that's not my training to work with fascia, sometimes I spend a lot of time on fascia. Yeah. So it's important that we have some willingness to entertain what we can learn from each other. And I think Ida and Moshe were interested in what they could learn from each other. So there's no reason why we today can't be interested.
Yes.
Well, thank you so much, Robert. I really appreciate it. I'm going to start wrapping us up here by letting us know what's coming up next. So in about 15 minutes after this talk with Robert, we will be having our live panel discussion with Anastasis Yotos and Stefan Iglid. I hope I'm saying those last two names right. And I'm very excited to have them. They both have a strong interest in the fields that have been in this track of biotensegrity and arts and fascia and research. So I think it'll be a really good discussion. You will be able to join in the live chat. I think Robert might even hang out in the live chat on that section with us. He's thinking about it anyway. So you might even get to talk with him directly, chat with him directly. And then, of course, later this evening, we'll have our next one after that at 7 o'clock. All times listed are Eastern's daylight time. So here for the Feldenkrais Awareness Summit. And we want to thank you, Dr. Schleip, for joining us. We really appreciate it and helping us to be connected, more integrated. And that is definitely one of my goals in forming the Feldenkrais Awareness Summit, is that we are, in fact, more integrated, more connected, and are learning from each other. So much appreciation to you for that.
Namaste.
Thank you so much. Bye-bye.
Bye-bye.